Knowlton, how are you?
Thank you for joining us today, and welcome to the Colorectal Cancer Awareness Month Physician Panel Discussion, brought to you by Dignity Health. We have an hour of valuable and life-saving information for you today. A bit of housekeeping before we get started. As this is a Zoom presentation, you will be muted during the presentation and panel discussion. Please remain muted and type all questions for the panel into the chat box. You will find the chat function located at the bottom of your screen. Also, if you requested the free at-home screening kit, we will be ordering those and mailing those out after today's event. So please allow delivery within the next week or two. Before I introduce your physician panel, please note we have another educational opportunity tomorrow at noon. Dr. Carl Balch will present a free virtual seminar, New Year, New Knees. To register, go to dignityhealth.org/Bakersfield/DocTalk. With that, I introduce to you your esteemed and talented physician panel for today's discussion. We have with us Dr. Lawrence Malalari, a colorectal surgeon practicing at Riverwalk Surgical Associates. He is also affiliated with Dignity Health Medical Group. Dr. Malalari graduated from the Robert Wood Johnson Medical School in 2009 and completed his residency in general surgery at New York Medical College, Westchester Medical Center. He continued his fellowship with colon and rectal surgery at UC Irvine Health and is thus board certified in both general surgery and colorectal surgery, wherein he practices advanced laparoscopic and robotic surgical procedures. We also have Dr. Robin Matuk, gastroenterologist with Kern Gastro. Dr. Matuk is a GI specialist with more than 20 years of experience in the medical field. Dr. Matuk has extensive experience with esophageal disorders, liver disease, and gastrointestinal disorders. He graduated from Rosalind Franklin University of Medicine Science, the Chicago Medical School in 2001, and is a board certified gastroenterologist. And finally, we have Dr. Kyle Heber, who is an internal medicine physician, a Bakersfield native practicing at William Baker, MD and Associates. Dr. Heber completed his internal medicine residency from UCSF Fresno Medical Center and is board certified in internal medicine. Dr. Heber specializes in health promotion and disease prevention. As an internist, he focuses on clinical expertise in diagnosing, treating, and delivering compassionate care across the spectrum of all medical illnesses. Doctors, thank you so much for taking the time to be here today. And as we kick off Colorectal Cancer Awareness Month, we look forward to what you have to share. And now I give you Dr. Malalari to begin the overview and discussion. Dr. Malalari.
Thank you, Patty. And thank you to Dr. Heber and Dr. Matuk for joining me in the presentation today. And thanks to everybody for taking the time to listen about an important topic, which is not a very interesting topic to talk to for most people, but it's a very important topic because it affects a lot of people, and that is colorectal cancer. March is Colorectal Cancer Awareness Month. And you may ask yourself, why do we spend a whole month talking about colorectal cancer? What's special about it? And hopefully by the end of this presentation, you'll understand why. So it's a quick overview of the presentation we have for you guys today. It's basically an initial presentation of what is colorectal cancer, why you should care about it, what is the scope of this disease problem in the United States, especially, and some of the long-term trends that we have recently noticed. We'll also talk about screening recommendations and types of tests available for colorectal cancer screening. and also for to identify the type of symptoms that are usually associated with this cancer as well. And finally, we'll talk about treatment options, more specifically surgery, and some of the new advancements that we have on in surgical management of colorectal cancer. And I have some videos at the end about robotic surgery that we do here in Bakersfield. If we have time to go over that or to listen to it. Okay, so beating colorectal cancer. What is colorectal cancer? You can see on the image on the right over there, the colon envelops most of the space inside of the abdominal cavity. It starts on the right, goes across the belly to the left, and goes down to the pelvis. There's a lot of real estate over there, basically. A polyp will usually develop on the inside lining of the colon. And over time, as this polyp grows, it can mutate and create basically a cancerous growth. That is what we call a colorectal cancer, because it occurs in these particular organs. When the cancer advances to other parts of the body, including lymph nodes or other organs, then it becomes metastasized. Again, it's caused by mutations in the cells inside of the inner lining of the colon and the rectum. And over time, this can cause, again, invasive cancer. There are some genetic predisposition for this as well, which is thankfully rare. But the evolution of the cancer, as you can see on the pictures over there, if you look at the picture on the left, the initial inner lining of the bowel, it's nice and flat and smooth. When a polyp or an abnormality develops, you can see that the cell starts growing over there and creating that growth of that polyp, which over time can turn into cancer and get through or get to the process of invasion, meaning it will invade the wall of the bowel itself. And as you can see on the pictures on a picture on the right, reach other parts of the body, including lymph nodes and other organs. That what is really going to determine the stage of the cancer. So stage 1 is when it's still within the wall of the colon. Stage 2 is when it has reached kind of the edge of the bowel wall. Stage 3 is when he's already invaded lymph nodes around the area where the cancer is located. And stage 4 is when it's invading or he has gone to other organs of the body, like the liver or the lung. That just to give you an idea of what we're talking about as far as, as far as the cancer itself. Why should you care though? Why should you spend an hour of your lunchtime here with us? Well, colorectal cancer is the third most commonly diagnosed cancer in the United States. It is the second leading cause of cancer-related deaths in the United States. More people die from colon cancer than die from breast cancer. More people die from colon cancer than die from prostate cancer. That is why we spend a whole month raising awareness on this particular cancer. It will affect both men and women. As long as you have a colon, you can get cancer in it, unfortunately. If you look at a lifetime risk for this particular cancer, about 1 in 23 men and 1 in 25 women will develop colorectal cancer during their lifetime, which means about 4.5% or so risk. But we're looking at 80 plus years, so it's a long life. The other issue with this particular cancer is that it does have very minimal and non-specific symptoms, and we'll go over the screening part section of the presentation. We'll go over some of those symptoms, and it's cancer, so it's a fairly significant life-changing news and diagnosis to receive. So what are we talking about as far as the scope of the problem in the United States? In 2020, an estimated 148,000 almost people will be diagnosed with this cancer. About 53,000 of them will pass away from it. If you look at patients who have been diagnosed with colorectal cancer and are currently dealing with it, whether it's with treatment or monitoring for recurrence, about 1.3 million of them are currently in the United States dealing with this problem. And yet, I showed you exactly where the cancer is. I showed you how it develops. We know exactly, the progression of this, which makes this cancer very preventable, very treatable cancer if we can catch it in time. That is the problem that we have with this particular cancer. If we have, if it's screened everyone that needs to be screened on time, about 40,000 lives would be saved every year. That is a huge number. Now, not to bore you with numbers and data, but he puts things into perspective if you look at it in this fashion, I think. The picture on the right is showing you the spread of the diagnosis of colorectal cancers by age group. And you can see as you get older, your risk of developing colorectal cancer goes up. And on the left side of the screen, you can see the spread of colorectal cancers by gender, males and females, and also by racial groups. And you can see that there are certain racial groups that have higher risk of developing colorectal cancer. The median age at diagnosis, however, is 67 years old. If you take all the people that get this diagnosis and you kind of put them on a straight line, the median of that line is going to be at 67 years old. If you look at patients who are people that pass away from this diagnosis, you can see on the right, the graph kind of shifted a little bit further out, which means that people that pass away from colorectal cancer are a little bit older than the ones that get diagnosed with it. And on the left, you can see the same separation by gender and by racial groups as well, to kind of give you an idea of how this cancer diagnosis has changed and the people that pass away from it. So if you look at the median age at death or passing away from this diagnosis is 72. Now, this graph is just to show you how important screening really is. If you remember from the initial few slides when I was talking about the ability of the cancer to start in the inner line of the colon and then progress to other parts of the body, well, this is why that matters. The first column over there that says localized disease, 5-year survival, meaning patients that were diagnosed with this cancer and alive 5 years after diagnosis. If the cancer is still within the wall of the colon, we have a 90% chance of cure of these patients. If the cancer starts getting away from that area, it goes to the lymph nodes, it becomes a regional disease, then you can see that survival drops to 71%, 71.8%. It's still reasonable, but you can see a big drop at that point. Now, once the cancer goes to other organs, like the liver or the lung, 5-year survival drops to the teens, 14%. That's a big difference. And this is where really screening comes into play, because we want to catch these problems and these polyps and these growths, ideally before they even turn into cancer. But even if they have turned to cancer, we want to find them as soon as possible before they have a chance to progress to advanced or distant disease. So if you take everyone that gets diagnosed with colorectal cancer and you find out how many of them will still be alive 5 years after diagnosis, that number is about 64.6%. So that's not very good. But if you look at long-term trends, that number used to be less than 50% in the 1970s. If you look at 1975 on the left over here, less than 50% of people that had this diagnosis were alive at 5 years. So our improvements in treatment, diagnosis, and surveillance as well has improved this number and has allowed us to increase the 5-year survival rates on these patients, but it's not as good as we'd like it to be or where we should really be, considering, again, that we know exactly where this cancer is and how to find it and how to treat it. Now, long-term trends, this slide is showing a similar finding, a similar basically idea of showing that as time has progressed, we've gotten better at finding this cancer. So the incidence is coming down, meaning we're removing those polyps before they turn into cancer. And the green line over there is showing that the mortality has gotten better as well. But there's a new piece of information that we have recently identified. If you're looking at patients who are less than 50 years old with a diagnosis of colorectal cancers over the past 18 to 20 years or so, you can see that the incidence of them getting this cancer is actually going up. Their mortality, which is the bottom line, has just started to move up as well. Now, the number 50 matters because as of this past year, actually, the recommendations were to get a screening colonoscopy at 50 years old, meaning that this group of people were not getting caught by the routine screening that we had. But we're seeing an increase in their diagnosis of colorectal cancers. And I mentioned earlier about some racial disparities as well, and more specifically, as far as African Americans are concerned, they have about a 20% higher incidence of colorectal cancer and a 40% higher mortality rate than whites as far as this particular cancer is concerned, which is important to be aware of. The Colorectal Cancer Alliance and has noticed the increased incidence of colorectal cancers in younger patients, which is why the Never Too Young campaign has been up and running for a few years now, actually. And the goal of this is to, again, to raise awareness on colorectal cancers, but also more importantly on the fact that just because you're not 50 years old or 60 years old, or you don't have any family history of cancers, that does not mean that you cannot get colorectal cancer. And just some recent, events this past year. I'm sure everyone remembers Chadwick Boseman passed away from colorectal cancer. He was 43 years old, and was fighting this cancer for about 3 years before that. And he was diagnosed at stage 3 colon cancer was when he was initially diagnosed. And the other picture over there, Will Smith, in 2019, got his first screening colonoscopy. He was not having any symptoms. It was just a routine screening because he was 50 years old. And the physician that did his colonoscopy identified precancerous polyps in him. So he dodged the bullet, basically. And that is the point. That is the point of screening, is to identify these precancerous polyps before they turn into cancer. Just to, again, reemphasize the importance of the data trends that we're seeing in terms of colorectal cancer in younger patients. In the 1990s, only about 6% of all colorectal cancer diagnoses in the United States were being made in patients who were less than 50 years old. In 2020, almost 12% of those diagnoses are made in this age group. That's almost 18,000 people being diagnosed with colorectal cancers, and they're younger than 50 years old. About 72% of these patients will be in their 40s, and more importantly, a lot of them will be diagnosed at advanced disease. They will be stage 3 or stage 4 at the time of diagnosis, so they're already behind the ball as far as treatment and survival is concerned because of it. And this is just telling you basically the incidence and mortality in patients less than 50 years old between males and females. And you can see that it affects both. It's not limited to one particular group. And since we have Dr. Heber here, and I'm sure he hears a lot about the difficulty in getting younger patients to get screened with this, and getting a devastating diagnosis of colon cancer when you're yourself or your family member is quite a hard news to hear. And I'm sure if Dr. Heber wants to chime in here about some of his experience with this.
Yeah, I mean, any diagnosis of cancer, especially in somebody far too young by the statistics in terms of the averages, is very shocking and alarming, and it raises a red flag in our mind because we have our history of understanding, okay, we start screening at 50, and colon cancer is much more common in older people, median age of diagnosis being 67, like Dr. Malolari pointed out. But we're seeing a trend and we're seeing a change. And if you look at the one of the slides that Dr. Malolari showed, 15 in total, I did the math, about 15% of the total colon cancer new diagnoses are in that 45 to 54 age range, whereas under 45, it's only about 6.6%. So that, I think, is what pushed the USPSTF and the American Cancer Society to start shifting recommendations and advising earlier colon cancer screening, which we're going to get to in a little bit. But it's always a devastating diagnosis, but it's always a good diagnosis when you say, hey, you had your colonoscopy and yeah, there were a couple polyps and we took them out, but everything looked all good. Or it's, the keystone, the one that makes you feel really good, is the story about Will Smith, where it was actually a more advanced precancerous polyp. That was not only diagnosis, that was treatment at the same time, because given enough time, certain polyps will turn into cancer. But if you take them out, they're not given the opportunity. And that's the whole point of this.
Absolutely. Thank you, Dr. Heber. So we'll move over to the next section right now, which is screening. And we have Dr. Matuk with us, who's an expert at this particular area. We'll talk a little bit about the symptoms, the type of tests that we currently have available, including the one that you may receive in the mail to get tested, and the current screening recommendations that we have from the American College Society. I'm sorry, American Cancer Society, and also the United States Preventive Services Task Force. Dr. Matuk, I'm not sure if he's unmuted yet, but this slide is just to give you guys an idea of where we really are right now. Now, these are screening rates. You can see by age group on the left and by years on the right. And you can see that we're not doing as good as we should, especially since we're dealing with a very serious disease that affects a lot of people. And these numbers don't even include last year's screening rates, which we expect to be atrocious obviously because of COVID. And colon cancer will probably not be the only cancer that has fallen behind, but especially because colon cancer screening requires a procedure like a colonoscopy, those numbers have dropped significantly, which is not good. Dr. Matuk, feel free to chime in
Sure.
when you're here.
So just to make I guess, elucidate on your point, Lorik, it's exactly correct. Last year, when we were shut down because of the COVID epidemic, I think the statistic was that about 80,000 cancers of all various types went undiagnosed or underdiagnosed or presented with late diagnosis. Because of that issue, we actually, in my practice, we had about 2 or 3 cases that were delayed diagnosis for 3 to 4 months with advanced cancers of the colon. So it's very important. But again, when people were uncertain with the uncertainty of what was going on, everything kind of got cold shut down. That's what kind of happened, and they're trying to catch up now with breast cancer screening, colon cancer screening, cervical cancer screening, the whole bit. But back onto our point with colorectal cancer screening, yes, we are seeing an increased incidence in the millennial population. Actually, released some data about that. 54% increase in one generation of the millennial population. The question is why? Why is that particular generation seeing such a high rate of increase? And the answer to that is nobody knows, but we can speculate. And I think it's more likely a lot to do with patients' lifestyles. Sedentary lifestyle, more processed food, more processed meat, obesity, smoking, alcohol, which are probably presenting in that population where we're seeing an increased rate. And yes, we are seeing, and we've had several cases now recently where we've had patients in their 30s presenting with advanced colon cancer. So we do see that. And again, the cancer recommendations, this with American Cancer Society, they kind of tossed the bomb to us about a year ago saying, hey, drop that age to 45. Whether it be colorectal cancer screening by colonoscopy, occult blood testing, Cologuard testing, but get them screened by age 45. Now, the provision of that is when patients have a very strong family history of colorectal cancer. For example, if you have colon cancer, which describes a first-year relative, meaning a sibling or a parent, which is less than age 60, you start screening that individual 10 years younger than the time of that diagnosis. So, for example, if their parent were diagnosed at 45, you'd find some way to screen them by age 35, because you want to basically find things at an earlier age, whether it be a polyp, which is going to grow into cancer, you can identify or remove it so they don't ever have to deal with that at a later stage. But back to our story, when you ask your questions, who gets screened? Well, yes, at 50, it's a no-brainer. But at 45, we really should start thinking too, as primary care providers and everyone else, that we start screening everybody in the population, whether it be by Cologuard testing, which I'll discuss in a minute, occult blood testing, which is a stool test for blood, or by colonoscopy, obviously gold standard being colonoscopy. But patients in particular, if they, can you jump back? I can't see your slide. As far as symptoms are concerned, colon cancer can be a silent killer. Okay, people go, well, I don't have any bowel problems. You're right. When you do have bowel problems, that means the cat's out of the bag. People start to lose weight. They may present with rectal bleeding. That's when usually you start seeing metastatic disease. So the whole point is to identify the disease before it ever becomes a disease, meaning as a polyp, which can be easily removed either endoscopically by colonoscopy, or if it's an advanced polyp, by the surgeon, Dr. Malavari. But when people present with unusual changes in bowel habits, change in the shape or caliber of their stool, rectal bleeding, abdominal pain, especially after the age of 45, Those are kind of red flag herrings. Obviously, some people may present very young with similar complaints like that. A lot of times they'll say, lack of a better term, poo-poo it off as an irritable bowel, it's a stressful bowel, or this, that kind of stuff. But, you know, in our line of work, we do find colorectal cancer in young people, especially with genetic predispositions. I found colon cancers, and Lauren, we can talk about that, in patients with something called FAP, familial polyposis syndrome, which is a genetic syndrome, at 19 and 20 years old. Now, those are very rare syndromes. However, it does happen. We do find colon cancers in those populations. We find them in 20-year-olds, advanced polyps in 20, 30-year-old, 40-year-olds. So when people have changes in bowel habits, rectal bleeding, or strong family history, we screen them. You know, it's like, you know, I'm using my little analogy. It's like asking a dermatologist to say, hey, what's on my skin, without looking at my skin. What we're doing is we're looking at the skin of the colon, and we're looking for what would be analogous to a mole in the wall of your colon, which could grow into colon cancer. We look at it with a camera, we find it, we remove it, and we move on, and we prevent disease at that point. Now, to our types of tests we discussed a minute ago, I guess the oldie but goodie would be the stool for call blood testing. Now, there are some more newer versions of that, which is the FIT test, or the DNA, or the immunotest for the blood, which is, you know, better than the original occult blood testing. But those tests, again, identify blood or occult blood in the stool. It doesn't tell me where it's coming from. That's the unfortunate part. It means there's some kind of blood in the stool. It could be from your esophagus to your colon, but it is a traditional screening test. Now, there's a new test, which is always on TV, called Cologuard, which is a genetic test. It's looking for DNA mutations, which are sloughed off in abnormal cells of advanced polyps and colon cancer. Now, they quote their data in their insert, and if you watch the commercial, it flashes by, about 91% sensitivity for detection of colon cancer, so meaning that if you have colon cancer, a diagnosed colon cancer, I did that test on you, it should pick it up 91% of the time. Now, not so great about with polyps, but you know, we've been burned with them a couple of times, meaning we've done them and found nothing, or we go in there and we found quite a bit of pathology, but it is a screening test. Now, to the primary care arena, and then again, if you watch the commercial, read the insert, that test is only for a specific population. They are average risk screening, meaning they have no family history of colon cancer and they have no history of polyps previously. I routinely get people who have polyps 5 years ago, they get a Cologuard test and it's positive. The test is about $800. And in that situation, that test is not indicated for patients that are higher risk, meaning have a history of polyps in the past. So you can skip the Cologuard and move on to the colonoscopy, because I'll give you an example. The other day, a guy 8 years ago had a colonoscopy. They had a Cologuard on him. He was supposed to come back 3 or 4 years after that, was positive, and I spent an hour and a half fishing large polyps out of him last week. So it was $800, not well spent. So it's meant for patients who are of average risk, meaning no family history of colon cancer, age 50-ish, and they have no symptoms either, meaning you're not going to bring somebody with rectal bleeding into a Cologuard on them, because again, that's not an average risk patient, screening patient, or a history of previous polyps.
Yeah.
Recommendations, again, the FlexSig kind of stuff with the FIT test usually is old Kaiser data that they accumulated back in the 1970s days. No one really does that anymore as far as a short scope. A flexible sigmoidoscopy was usually done by a primary care doctor in the office. It's kind of uncomfortable, it's unsedated. Those aren't really done anymore with the occult blood testing. Kaiser still does it as a HMO, but really it's not really the standard of care anymore. The full colonoscopy takes about 1 minute longer to complete than a flexible sigmoidoscopy, so it's just not done. So if you're going to refer someone, it's not for FlexSig and occult blood testing, it's for full colonoscopy. Now, as far as colonoscopy is concerned, people have their most angst, I think, is basically about the prep. So my advice to that is we live in a kinder, gentler world anymore. We don't give the big jug of soap said go lightly to anybody, obviously, unless we don't like you, and that's a joke. So what we use is Miralax, which is over the counter, doesn't taste bad. You mix it with Gatorade, you mix it with Crystalite, you throw it in the fridge, refrigerate it. What you put it in is what it will taste like. So you drink that stuff over a couple hours a day before, and that's what cleans you out. The next day, we bring you in, and the next question you may ask is, do I need to be sedated? The answer to that is no. When I worked at the VA, a lot of guys say, hey, I don't want sedation. That's okay. Now, personally, I prefer to have a little bit of sedation, but what we traditionally use in healthy people is what we call conscious sedation. It's like being a bit buzzed and having a couple of martinis. So you become forgetful, you're happy, a little comfortable. We use a little camera. We look in your colon. Test takes about 15 minutes. And a lot of people will watch the test. Some people want to sleep through it. That's okay. Some people watch the test. That's okay too. But we will look. If we identify pathology, we remove it at the time of your procedure, if possible. Now, if it's an advanced polyp, large flat lesion, or colorectal cancer, obviously that's Dr. Mallory's arena. So we refer them to see him to get them out. However, during our procedure, we can take out probably more than 90% of polyps during that procedure in a 10 to 15-minute interval, and that's the end of it.
And maybe Dr.
Um,
Heber can chime in on what he hears from his patients when you offer them to get a colonoscopy. Or what excuses, I guess I should say.
No, it's mostly people are just risk averse, and a lot of people are coming to me, especially when they're at 50. They'll bring it up, say, "Hey doc, I'm 50. I'm time." They've got it in their mind. They already know, or they already know that I'm going to ask them as part of their annual physical, either if they're coming to me new or if I've been seeing them for a couple years. But then obviously, as part of an annual physical, I always bring it up if they don't bring it up themselves. And mostly it's about people that are afraid of either the procedural sedation, risk of complications. There are low risk complications that do happen with this thing, and sometimes it requires surgical intervention. Those are overall rare, especially given the number and the volume of colonoscopies that are done per day. And I'm sure Dr. Matuk and Dr. Malalari can speak to the statistics and numbers on those complications. People don't like the prep, and it's harder on older people that are less mobile, or that already have urinary or bowel issues or mobility issues that prevent them from getting to the bathroom on time, or a lifestyle that doesn't, they've got to take a couple days off work while they're doing the prep, and they've got to stay close to the bathroom while they're prepping. I mean, you need to do that in order to have a good quality study. Because it's kind of a pointless test if the colon is not adequately cleaned out. If Dr. Matuk can't see what he's doing, then he can miss polyps.
We're talking about polyps. Let's see what they look like.
Yeah, but mostly it's people that are either fearful of risks, especially if they've had family members or friends that have had bad experiences, or they're afraid of pain. Pain and sedation is generally not a very uncomfortable test as long as people are adequately sedated, which I guarantee you Dr. Matuk will take care of. But those are the main things: risk of complications, not wanting to do the prep. Those are the big barriers.
All right, Dr. Matuk, so going back to you, we got some polyps on here. So what are you gonna do with all this stuff?
Well, back to real quickly with there's always risk of complications of any kind of procedure. The risk of complication during diagnostic colonoscopy is 1 in 6,000, causing a tear or perforation of the bowel wall. I mean, it does happen. Unfortunately, we don't like it to happen, but that does happen. But the rate of colon cancer in the general population is 1 in 1,000. So you gotta look at the math. Now, when we take a large polyp out, if you could refer to your left side here on your screen, the risk of complication with a large polypectomy can be anywhere from 1 to 500 to 1 in 1,500, meaning causing bleeding, removing one of these polyps, which we can typically control endoscopically with a scope, or even causing tear or perforation, meaning removing the polyp from the bowel wall. Now, in that situation, obviously we require surgical intervention to repair it. But the flip side is if we leave that there, then you're going to have surgical intervention to remove it regardless.
Yeah.
So the flip side is that's a colon cancer, or those are advanced polyps where if we can't remove it, it's going out. If we do remove it, there's an injury, obviously has to be repaired. If we don't remove it, then Dr. Malalari has to open you up and remove it regardless, because you'll get colon cancer from this lesion for sure. So it's something that there's always a risk in life, unfortunately, but we do our best to prevent that. But the flip side is colon cancer is deadly. And that's
absolutely. And I just have some pictures here on the, one of the ways to remove polyps. So I don't know if you want to.
Sure. So what this is here is what's called a snare. And if you're looking at that polyp, it's what we call a pedunculated polyp. Looks like an ice cream cone. So the polyp base of it is a little bit of a stalk, which is typically free of any polyp tissue. And above that big cone there, the ice cream, is basically the tissue, which is the abnormal, which is what grows into colon cancer. We got a little bit of like a lasso, like you're lassoing a steer, which is basically attached to what's called electrocautery. So it cinches around the base and it cauterizes as it cuts. So it basically destroys the tissue, it burns it to prevent bleeding, and seals it off such that we can remove that polyp safely. Now, as you can see in the third screen, you see that thing floating away. It kind of flops over and we take it off. Now, if we do that, we also have some kind of fancy stuff, which is not shown here, which is called an endoclip, which is kind of like a suture. So if we are concerned about any kind of injury or bleeding, which may occur after that, we can actually put sutures in the wall of the colon after that to prevent any bleeding or problem post-polypectomy or after removal of the polyp. But that polyp there would be about a 2 to 3 centimeter polyp, which would be described as what we call a high-risk polyp for developing colon cancer. 1 in 50 polyps of that size do already harbor cancer within them. So again, it's very important to identify and remove them at the time of your procedure.
Absolutely. and you can do this at the same time as the colonoscopy. And I
Yep.
just wanted to bring up the fact that, you know, the colonoscopy is the gold standard screening for colon cancer. And one of the main reasons that it's a gold standard is not just improved visualization. Obviously, you can actually see the polyp rather than get a test to tell you that there might be one. The other part is that it's not just a diagnostic tool, but it also is a treatment tool, because you don't just find a polyp or you identify and you look at it and you take pictures and you come out. You can actually do something about it, remove it, biopsy it, get an answer basically on that problem. And none of the other screening tests that we currently have available will be able to do the same thing. And the other thing that I get asked sometimes from patients about doing a Cologuard, for example, like we were talking earlier. The other problem is that if any of those tests comes back abnormal, a FIT test or a Cologuard test or what have you, the next step is a colonoscopy. So you still basically have to do the colonoscopy anyway in order to identify the location of the cancer. And this kind of moves us over to the next section on the presentation. We're talking about treatment options and more specifically surgery. We'll talk a little bit about some advancement surgery as well, but surgery is kind of like a real estate, location, location, location. Where the cancer is, where it's located in the bowel will determine, what kind of surgery you're going to have, how, which part of the bowel needs to be removed and things like that. So timing matters. The sooner you identify the problem, the more circumspect the resection or the surgery can be done, the more minimally invasively can be done. So if you catch it earlier, you can treat it endoscopically, even avoid surgery. But if it's too large to be removed with a colonoscope, or if it is cancer already and needs to be resected, surgery and sometimes chemotherapy is needed as well. For the rectum, we also add radiation to that. So the goals of the surgery are primarily obviously to remove the cancer, but not only remove the cancer, but stage the cancer, meaning that we need to know how far did the cancer grow through the wall of the colon, and also whether it has reached to the lymph nodes around it, meaning remove it, but also find out what's happening in the regional areas. That will allow us to better stage the cancer on these patients so that we can identify those who are stage 3, for example, rather than stage 2 or stage 1, so they can get that additional treatment to get the cure that we hope to get with colon cancer. But if you don't have that piece of information, you're not going to get adequate data on it and stage them appropriately. And how do we do this surgery in as minimally invasive fashion as possible? Surgery is a very invasive procedure. You're cutting tissue, you're cutting muscles, you're going inside the belly to maneuver bowel around and cut the bowel edges and put things back together afterwards. So it's quite a traumatic, procedure, a traumatic event on the body. How can we do this in a way that hopefully will allow patients to get over this with minimal discomfort? And that is where MIS, or minimally invasive surgery, has come from, and that includes laparoscopic surgery and robotic surgery as well. And as I mentioned earlier, location matters with cancer surgery. If you look at the picture on the left of the screen over here, that blue blob is where the tumor is that Dr. Matuk identified. Then I have to go to surgery and remove not just the area where the cancer is, but around that region as well, in order to get the appropriate margins on the bowel and also the lymph node basins as well. And then we can't kind of let things be there. We have to reattach the intestinal tract. And it's like, we have different ways of putting those bowels back together. But that's what we do. And the same thing on the picture on the right, if the tumor is in the middle of the bowel over there, that whole area has to be removed. And then we have to connect the other ends of it. So the way I sometimes describe this is like plumbing work. You have a plumbing problem that needs to be fixed. The only problem is that with surgery, we can only use the plumbing that you already have in you. We can't get any extra ones from Lowe's or Home Depot. We have to use what you got in you. But we're usually able to get this taken care of. So some of the advancements in surgery and minimally invasive surgery, more specifically, the previous surgical technique was basically open abdomen. You can see the picture over there. You're using your hands to go inside the belly and do the procedure that you're trying to do. Laparoscopic surgery allowed us to do a similar procedure, basically with smaller incisions and put instruments in it. But the limitation of laparoscopic surgery are that you're working with basically straight instruments or chopsticks, basically, that you don't have the articulation of a wrist or a finger inside of the abdomen. The articulation is outside of the body. So it does limit some of your mobility inside of the abdomen and the amount of dexterity that you get during the dissection. That is where robotic surgery really came about, and that was the point of actually robotic surgery being developed. So I mentioned the open surgery. This is basically a patient that had open surgery. You can see the incision is significant. That's where the belly button is in the middle. You can see the incision is from above it to below it, because we have to, put instruments and hands inside the abdomen in order to remove the ball that needs to be removed. When you're looking at MIS, laparoscopic or robotic, this particular patient both had actually robotic surgery. The one on top had his whole colon taken out through those small incisions that you see on the picture. This is actually a picture in the operating room. This patient had just completed his surgery. And he has a stoma on the side over there because his whole colon, again, was taken out. This patient on the bottom had her sigmoid colon taken out because she had a cancer over there. And you can see that was done through those incisions on the right side of the belly. When before you would need the incision that you see on the left over there. All right, so the other advancement that we have now in robotic surgery also include what's called intracorporeal anastomosis and transrectal or even transvaginal extraction of the specimen, so you can avoid even that phenosteel incision at the bottom that we usually use in order to remove the ball out of the belly. And those, are coming about now. This is basically what robotic surgery would look like. You can see on the picture on the left over here. That's what the operating room would look like. The patient is sitting on the table. There's an assistant sitting next to the machine, and the surgeon is sitting on the console on the side of the room over there, controlling the robot and actually doing the maneuvers that the robot arms are doing in order to proceed with the surgery. And you can see the instruments that I've, that picture in the middle over there showing, they're very small. That's a dime over there, by the way, just to give you a sense of the size. The diameter of the shaft of a robotic instrument is about 8 millimeters. So you're basically making an 8 millimeter incision, putting in an instrument inside the abdomen that can rotate like your human wrist will, as you can see on the picture on the right over there. The same maneuvers that my wrist would be doing inside of the patient's abdomen, this robotic instrument allows me to do from outside and through those 8 millimeter incisions. And what happens when you're able to do that? Well, here's a patient that had her right colon taken out. You can see a picture from the operating room. Those are those metal, chokers that you can see over there. That's where we connect the robotic arms. And when the procedure was completed, the picture in the middle tells you, basically what she had when the surgery was over and she was waking up from surgery. And the one on the right tells you, what her belly looked like 2 weeks later. You can barely see the incisions. And it's not just cosmetic, obviously, but the smaller the incisions are, the less pain these patients will have, the more activity they'll be able to do faster than they would otherwise, and obviously the shorter hospital stay they would need so they can get back to their families and their life sooner. So I have a few videos here, robotic surgery, and I'm not sure if you're going to have some time there, so I'll probably play them in the background, but I wanted to take a minute to go over some of the steps that you can do to lower your risk of colorectal cancer. And Dr. Heber and Dr. Matuk kind of mentioned this already, but just wanted to kind of summarize it at the end. So get your regular screenings. Current recommendations are start at 45. Whether you have or you do not have symptoms, you should get a colorectal screening at 45. There's caveats to that, like Dr. Matuk mentioned, if you have family history or you have symptoms, you may need to do it even sooner than that. Eat plenty of fiber. This is where the dietary changes come into play. The current recommendations are to take between 20 to 35 grams of fiber every day through fruits, vegetables, fiber supplements, nuts, beans, all the healthy stuff that we all know about that don't eat as much as we should. Eat a low-fat diet. Foods that have folate will decrease your risk of colorectal cancer, and that includes things like leafy green vegetables, basically. Don't drink excessive alcohol and don't smoke. If you don't smoke, don't start, obviously. And exercise. The recommendation is about 20 minutes of exercise 3 to 4 days a week. This is not going to the gym and, lifting weights and running the treadmill for 20 minutes. Any exercise counts. Even if you're walking around your neighborhood, you're taking a stroll to the park, about 20 minutes, 3-4 times a week is enough to lower your risk of getting colorectal cancer. And this just basically kind of summarizes in a picture form here, the same recommendations. All right, I'm going to let we have questions I think Patty is going to bring up here, but I'm going to let the video play in the background, and Patty, you can take over with the questions.
Yes, awesome. And I do know that Dr. Matuk has to run because he has clinic and some consults he needs to do. So I do have at least one question I'd like to ask him, and it's going to be a two-part. So Dr. Matuk, is there times when you may need to take more than one type of test? And does the at-home fit test replace a colonoscopy?
So the answer to that is the at-home fit test does not replace a colonoscopy. It's a screening examination for occult blood. Now, as I mentioned earlier, it says, hey, there's blood in your gut, whether or not sometimes people take iron tablets, the thing will give you a false positive. Some people eat red meat inadvertently before they do their test, a false positive. But it may indicate the presence of polyp or cancer of the colon. It may indicate the presence of polyp cancer of the small intestine or even the stomach. So it does think that it possibly could be bleeding, but it is a screening test. It's okay, but it's not the gold standard for screening for colorectal cancer. It's usually, I typically use it in patients who basically are reluctant to have a colonoscopy for various reasons, meaning age, comorbidities, but it is not the gold standard test, so it doesn't replace a colonoscopy by any means. And sorry, Cheryl, what was the second part of your question?
That was pretty much it. Other testing.
Other testing, colonoscopy, again, gold standard. Now, if colonoscopy cannot be performed for various reasons, meaning age, comorbidity, some kind of an anatomical thing, there are other alternatives. For example, some people, colonoscopy is not possible because of their anatomy, whether they have scar tissue adhesion, some issue like that, or they won't tolerate sedation. So there are other options, something called CT colonography or a barium enema, which is the old version of that. Now, they're not very sensitive tests. Even the CT colonography, which was introduced around 2005-2006, really can't identify polyps less than 1 centimeter in size. It's not very good at discriminating between large fecal balls or stool balls in the colon and polyps, and flat lesions is abysmal at looking at. So there are alternatives. They're not great alternatives, but they're not the gold standard by any means. They're just alternatives in the situations where we cannot perform a colonoscopy, essentially.
Okay, awesome. And if there are polyps found in a colonoscopy, how soon should you come back for your next treatment or your next test?
Well, good question. So that depends on the size, number, and family history. So the typical recommendations are that if you do a colonoscopy, good quality prep, no family history, and you don't have any polyps, we would see you back in 7 to 10 years. Now, people with family history of colon cancer, and again, the first relative or multiple secondary relatives, we typically screen them regardless at 5-year intervals, whether they have polyps or not, because it puts them in a higher risk category. Now, patients who have had polyps in their colon, it's a different situation. It depends on the size, number, and the pathology. But in a nutshell, if you have greater than 3 precancerous polyps in your colon, during a colonoscopy, we see you back in 3 years. Or if we find a precancerous polyp greater than 1 centimeter in size, which is considered a large high-risk polyp, we bring them back in 3 years. If we find 3 or 2 or less polyps, which are precancerous, we typically bring people back in 5 years.
Okay, wonderful. Thank you so much, Dr. Matuk. And I think I have one here or two I can share for Dr. Heber. One is, it says to have a high fiber diet or low fat diet and high fiber. What is your option on a keto diet? And then a second question is, does diverticulitis increase the risks?
So as far as the keto diet is basically beneficial for a diet that is people who have health issues related to diabetes, are overweight or obese. They're trying to lose weight, and it's not really a long-term sustainable diet. Speaking from experience and seeing family and friends and patients that do the keto diet, yes, it can be good for short-term weight loss, but it's not very good for long-term. What that short period of term of how long people are doing the keto diet, what that actually does in terms of one's risk, in terms of numbers and increased risk of colon cancer, we don't know that, but that hasn't been studied. But bottom line is, keto diet is basically incredibly low carb, but it's very high in fat. fats and red meats and dairy are the things that are high risk for colon cancer and diverticulitis and other colon and GI pathologies. So it's not a good thing for someone's colon cancer risk, but we can't necessarily quantify it in terms of numbers. It's also not a very good thing for cardiovascular health in general. Although I may have some people that are overweight, if they have a scary cardiovascular history, they've had heart attacks, they've had a bypass, they've had a stent or a stroke, I don't recommend keto diet for those types of people. And if somebody has a scary family history of colon cancer, I would not recommend a keto diet really to help them with weight loss. It's a very good question.
Wonderful.
Yeah,
Thank you
Patty,
so
for your about the diverticulitis question, the answer is no. Diverticulitis alone does not increase your risk of colon cancer.
Okay, thank you so much for that answer. And I had another really good one that came in the registration process, and it says, I had cancerous polyps removed and under it were irregular cells. Now I have irregular cells in my cervix. Any indication if these are related?
Right.
Could be.
So I can probably answer that one. So the cancerous polyps or cells really that we find during colonoscopy and polypectomy are different than abnormal or precancerous cells they find on cervical, like Pap smear, for example. Those are actually two separate cancers. Cervical cancer and colorectal cancer is a different type of cells that create that cancer. You can have anal cancer, though, which is actually caused by the same culprit that cervical cancer is caused from, which is a viral infection, namely HPV. Colon cancer is not affected by that particular cancer. So I guess the short answer to that question is no. Having precancer polyps in the on colonoscopy does not increase your risk of getting an abnormal Pap smear or precancerous cells in your cervix.
Okay, thank you so much for that answer. And another one here is, if I have adhesions due to previous operations, how can I be checked? My father died from colon cancer.
Did you say adhesions?
Adhesions, yeah.
Okay, so the as we discussed a little bit earlier, the screening tests, colonoscopy, stool tests, they all have pluses and minuses, and they're good for most people. If you have a strong family history of cancers, then ideally I would recommend that that patient receive the colonoscopy first. Having adhesions, the adhesions are inside of the abdomen, not inside of the colon. So you should be able to obtain a colonoscopy. There are cases when those adhesions kink the colon in really sharp angles, at which point we're not able to advance the scope to get a colonoscopy. In those cases, then doing tests like a Cologuard test or a stool test will be appropriate for that patient. Unless there's a high suspicion for a mass or cancer, or if that test comes back negative, at which point then the adhesions may need to be addressed surgically before colonoscopy is done.
Okay, and I have one more here in the chat, and we're getting close to our hour. So the one in the chat I have is, clearly insurance companies are going to push back on the screen age change recommendations on helping age 45 become acceptable to the insurance industry.
Right. So that's actually a very good question, because the American Cancer Society recommended getting screened at 45 in 2017, so almost 4 years ago now. But, and Dr. Heber brought this up earlier, the United States what's it called? The USPSTF.
I just use the acronym. It's a lot easier.
Yeah, they actually are finalizing a rule this year about lowering the screening age to 45, which will force coverage by Medicare, Medicaid, and all insurance companies.
A big, if I could chime in on that, we see this a lot, not just in colon cancer screening. We also see this a lot in disease treatment and process. The medicine and the studies that come out in the journals that inform us of the latest cutting edge, what is the best care for our patients to reduce their risk, whether it be diabetes or preventing heart attacks or strokes and such like that. The medicine and the data that of certain medications and treatments that will lower someone's risk of other things. Say they're a diabetic and we're trying to lower their risk of a heart attack later on. The medicine always runs ahead of the insurance companies. The medicine starts, and then it's worked into the guidelines, which we use as general, like I said, guidelines, rules for us to go by as to what is the standard of care and what do we feel is going to do the best for our patients to help them live longer and healthier and free of disease. The last thing to happen is the insurance companies and what they will cover. Because even though we might know what the data is and the number is on the best medication or the best test or the best screening, the insurance companies, it takes them a while and a lot of lobbying to get them on board to start changing their coverage. So it's on us as providers to push and advocate for our patients, which we do, and I think we do very well in our office, and I guarantee you other providers here in town do as well. Is to lobby for what we firmly believe is what needs to be done and what is the standard of care. The change it's slow to come, but it just kind of requires, unfortunately, lobbying and there's a lot of politics involved with that as well.
Yeah.
Awesome.
Well, we finally got it though. This year should be finalized. The rule is already out there.
Yeah.
Oh, good to hear. Good to hear. So with that, you guys, we are coming along. It's 1 o'clock now. So we have finished our hour. I know there was still some more questions that we weren't able to get to, but if you have other questions, I've put up the screen here so that you have the contact information for each of our panelists today. And from all of us at Dignity Health and the providers organizations, we thank you so much again for joining us and for asking such good questions. We hope you enjoyed the education that we provided for you. A reminder, we have the New Year, New Knees coming up tomorrow with Dr. Balch, if you'd like to join that. Also, if you did request the at-home test, please allow 1 to 2 weeks for delivery of that. And that concludes our colorectal cancer physician panel discussion today. So thank you so much for joining.